So, those of you who listened last year or were present last year, you knew that we did the treatment highways last year. So this year we get to add two new stops to the treatment highway. So we're going to go through and talk about that specifically. That's the more important part of this session. But I also want to give you some background because often the question we get is, why didn't I get diagnosed faster? Or what was the problem with why I didn't get diagnosed faster? Or a number of other things related to that diagnosis. So we're going to go through it. So you've heard already that we got one drug approval on March 20th, 2025, and then, of course, the second one on July 28th. And so Richard and I are in the midst of creating a slide that catalogs, our first publication in this space was back in 2012. Actually, with the first set of agents that were tried, et cetera, et cetera. So we'll get that one to you actually fairly soon, but we're going to do just the new stuff here. So, or just the stuff that works. How's that? I'm obligated, obviously, by the university to give you my disclosures. What you really should see there is, as Richard already mentioned, we've been involved in every single complement inhibitor that actually was taken to humans. So I have a lot of that going on. So what are the challenges in the diagnosis? And the first one is it's a biopsy diagnosis. Richard shared that with you, but that might seem black and white, but the real problem is that there are many different patterns on the biopsy. There are many different types of deposits on the biopsy. Yes, C3 is the critical aspect, but there can often be other things. And Richard already gave you the preview of the fact that even if C3 is there, it's not necessarily C3 glomerulopathy. So we'll talk a little bit about that. And I don't want to make it more confusing for you, but the bottom line is that other than that biopsy, we have no other single lab tests that actually will prove to you and your physician that you actually have C3G. So it's basically a collage of everything that you present with that actually makes it a lot easier for anybody to actually make the diagnosis for you. And then to make it even worse, and we certainly have had this in our practice, you may have been diagnosed with immune complex MPGN on the first biopsy, maybe even the second biopsy, and then all of a sudden on the third biopsy, you get C3G, and then on the fourth biopsy, you're back to immune complex MPGN. So there can be some back and forth on this. In our database, it might be as high as 12% of patients can go back and forth, but actually in the Columbia database, for instance, they reported that it happened in up to 8%. And even importantly, I brought this because we have this frequently where we get asked, well, if I have these things called subepithelial humps, then it must be post-infectious. I'm not going to worry about it. It's not really C3G. Aha, it's not true. Turns out that plenty of patients, even dense deposit disease patients, will actually have these humps. So what we used to say is that if you have those subepithelial humps, you can say you're not C3G, no longer true. So really what I'm getting at here is there's lots and lots of confounding things before you actually get finally to your diagnosis of C3G. Then there's the issue of the number of the confounders that exist. And Richard mentioned already the issue of C3 or of post-infectious glomerulonephritis. And in fact, the biopsies can look exactly alike to your physician. There is no way for me, for Richard, for our pathologist, there's no way for anybody to be able to tell the difference in that biopsy and a C3G biopsy. It's the unfortunate truth. But again, we go back to, it's the constellation of things that you actually have that will actually seal the diagnosis for you. We use this idea of, ruling you out, meaning if you have a C3 that was very low and it goes into the normal range within 12 weeks, then you're probably not C3G. You're probably post-infectious. But we have even patients in this room where their C3 went into the normal range at 7 months, meaning they didn't quite read the book, right? So, but they turned out that they probably didn't have C3G, even though it did, they had that slightly different phenotype, if you will. But this is the major issue is that post-infectious GN is a complicating issue. Then to take it one step further, there are lots of opportunities to have C3 deposition that can confound the pathologist or the local nephrologist, et cetera. And one of the things that we've, noticed over time here is this idea that is there local activation of complement at the level of the kidney? And this is another whole topic, but factor D, one of your biomarkers, it climbs the worse your kidney function gets. It happens to be the rate limiting step of the complement complement system. So we don't know this, we don't have an animal model for this, but if you have a very active complement system because factor D is present or in excess, could that contribute to some of this C3 deposition in these late stage or near end stage kidney disease biopsies? It's possible. We don't know the answer to that, but the point is, again, end-stage kidney disease biopsies can have lots of C3 deposited. In fact, I warn my families when I see them, beware of this diagnosis called C3 dominant sclerosing glomerulonephritis, because I cannot tell you that that is actually C3G. That may actually be something completely different than C3G. So I hope what you're getting from some of these things that I'm telling you is that it's a difficult diagnosis to make at times. Sometimes it's real easy, but most times it's a little bit difficult. Then there is C3 deposition on biopsies that are black and white. They're diabetic kidneys. But if you didn't know it was diabetes and all you saw was the C3 deposition, you might call it C3 glomerulonephritis if you're not careful. Similarly, even FSGS patients, so focal segmental glomerular sclerosis patients, can have, they're not supposed to have a lot of immune deposits at all, period. But sometimes they can have C3 deposits. And if that's the only deposit that's there, the physician or the pathologist may make a comment about it being C3 dominant glomerulonephritis, and then you're stuck trying to figure out what it really is. And then, of course, there's paraprotein-related disease, which we won't spend a lot of time on. Richard introduced this concept just a little bit too, and I know I talked to you all about it last year, but I really want to go through these three terms because again and again and again, they are confusing, and even to our physicians, but there are three terms that we need to be very clear what they are. C3 glomerulopathy is the disease. It's the disease that has C3 dominant glomerulonephritis with underlying complement dysregulation. That's the full definition of the disease. You can't pick just half of that. You have to have the whole definition of the disease. Then, and by the way, that was from the consensus statement. Then there is C3 dominant glomerulonephritis. So the dominant's the key point there. That's the one that confuses all of us because that's what the pathologist calls. That's what he sees on the biopsy, C3 dominant glomerulonephritis. The problem is that C3 dominant glomerulonephritis could be that diabetic kidney. It could be a post-infectious GN. It could be that sclerosing glomerulonephritis, et cetera. So again, I want to make the distinction when you see, or when your nephrologist sees C3 dominant glomerulonephritis on the biopsy, they should not jump automatically to the fact that it's C3G. There's a number of other pieces you have to go through before you can get there. And then to make things even more complicated, we, at the time that we were naming these diseases, decided that C3 glomerulonephritis made a good description of what the non-DDD form of this was. So it's a little bit too close to C3 dominant glomerulonephritis, but nonetheless, if you keep those categories really clear in your mind, I think it gets a little bit easier to keep these separated. Two more slides on why it's hard to even get to whether you need one of these new therapies is this idea of delayed diagnosis. And this was actually, it was just a poster, so I don't have a publication for you yet, but basically they polled physicians in the Europe, US, China, and Japan. And the time from symptom onset to the first consultation with the nephrologist, by the way, can be up to 17.6 weeks. That's a bit hefty as far as the timing, right? And then it even can take, after you've had that consultation, another 13 weeks to actually get your diagnosis. So you can see that the delay in diagnosis is still going to give us some problems, even now that we have some potentially good medications. So much so that up to 10% of patients wait 5 months to get their diagnosis. That could be very problematic for a fairly progressive patient, meaning you are accruing scar potentially during your 5 months while you're waiting even to get the diagnosis. Monica and I have seen more than once, we've seen patients who pop into our clinic who's taken more than a year actually to get their diagnosis because they see several different kinds of physicians before they actually get to the pathologist who is actually going to be obviously very important in making the diagnosis. What about immune complex MPGN? I only bring that up very quickly because it's in some of the newer trials, and the bottom line is that some of immune complex MPGN patients may actually be C3G patients. It's just that we happen to have biopsied them when they had an infection that triggered the classical pathway, so they have just a little bit too much classical pathway activity on their biopsy. But when we biopsy them again, they truly are a C3G patient. So that's a little bit complicated. Then you have oh, by the way, the French group says that immune complex MPGN patients are just as likely to actually have complement abnormalities, whether it's genetics or whether it's autoimmunity. Now, I will argue that they didn't do repeat biopsies. Do they know whether they're truly IC-MPGNs or whether they're C3Gs if they had rebiopsied them? But nonetheless, we're still going to be looking for complement abnormalities. And in fact, you guys will know, and I'll present it very shortly in case you don't, the newest trial that was actually got FDA approval actually treats immune complex MPGN exactly like C3G. If animal models are correct, immune complex MPGN is some combination of alternative pathway and classical pathway activity, but we don't completely know what it really is in humans. So it suffice to say, moving forward for our discussions here and for many of your clinicians, it's going to be treated very similar to C3G, even though it may not be C3G or certainly at the very least on a distant cousin of it. Okay, let's go to the treatment piece. Uh, you've seen this probably a million times. We participated in KDIGO, Kidney Diseases and Global Outcomes, which is the global approach to treating disease. And this is what we've been working on for, well, at least since 21. But truthfully, we've been using this type of approach for many years before that. Basically, the bottom line is it was not based on trial data. We chose at the time that you start treatment or you get more serious about your treatment when you get to 1 gram of urine protein. You could argue in a young adult, a young patient, that's way too late to decide to begin treatment. So we were guessing, frankly, at that time, but we had to choose something. It was retrospective, meaning it's not controlled. And then finally, it was the generic approach that we were trying in a lot of other things. If you had lupus nephritis, this was the approach that we took. If you had any number of the other glomerular diseases, this was the approach we took. But it actually didn't have the best efficacy, if you will. So again, no clinical trials. The response across each of these patient populations was actually quite different. And I colorized this to make it a little bit easier, but the green boxes are the ones that responded. But look at all the red boxes. Those are the ones that actually went to end stage on their mycophenolate and on their steroids. So you can see that even though it was the best we had, it certainly wasn't very effective. So now, let's go directly into the new stops on the treatment trial highway. And the first one, and I'm doing these, by the way, in the order that they were actually FDA approved. So factor B inhibitor, you'll know this as an oral agent, 200 milligrams by mouth twice a day. That's where factor B is. You saw that in Richard's picture, but you can see where factor B, if you inhibit factor B, this is where you're going to inhibit the alternative pathway. This trial specifically was in 18-year-olds native kidney disease. The phase 2 trial for the iptacopan, or this is called Fabhalta also, by the way. The phase 2 trial actually had their transplant patients. And this was the adolescent, and the adolescent group is still ongoing, if you will, in the C3G trial. And then finally, the adolescent and adult group is still ongoing for immune complex MPGN. That's important because I need to give you a comparator for the next trial. And luckily for this group and for us, in terms of understanding whether it was going to work or not, there were mouse models, or there was a mouse model that suggested that this drug should work very nicely. So Richard is the senior author on this paper. It was published literally Friday of last week, I think it was, but in the Lancet. So this is a very good journal to pay attention to, frankly. But there is a relative reduction of proteinuria of 37.8% in those patients that were exposed to iptacopan. Proteinuria dropped as soon as 14 days, and that's one of the things I often get asked. You can see a very significant drop in the urine protein very quickly. Obviously, they're showing day 90, but they actually had the data even at day 14. So we know that if patients are going to start responding to iptacopan, we may see some improvements quite quite quickly, actually. So at 1 year, iptacopan treated patients still had at least a 40% reduction in urine protein. And that's important for a couple of reasons. There are the other complement inhibitor that's been used for a longer period of time, which will remain unnamed, kept some urine protein reduction, but then lost the urine protein reduction over time. So it's important for you to actually see that we are continuing to have urine protein reduction in this group of patients. And in fact, when you flipped over from being on placebo to being treatment, you then gained that nice urine protein reduction. And you can see that actually, that when this is the placebo group who was not getting any protein reduction initially, now they're getting a nice protein reduction. And so that's really what I wanted you to see there. Very quickly on the composite endpoints, that basically was stabilization of the kidney function, and also the urine protein reduction. You can see that if you were treated with iptacopan, you had a 30% chance of reaching the composite. If you were on placebo, a much slower percent chance. And then if you moved to you can see that if you moved your placebo patients to iptacopan, in fact, they also were able to achieve the composite endpoint. So really what I'm showing you here is that you are getting proteinuria reduction, you're getting stabilization of the GFR. I don't know what I did. Then finally, we'll go through renal function very quickly. I want to share with you the 6-month data said that you get an eGFR change, so a glomerular filtration change of plus 1.3%. And you may or may not know if that's significant. So I'm going to share with you in just a moment what you would normally get. But that eGFR for the placebo group instead was minus 0.86%, 0.86 milliliters, if you will, at the 6-month mark. So in that group that was on placebo only. So here's what I really wanted to share with you. Again, I wanted to share that it goes for an entire year. You're still getting benefit. But what they know and what we know from the natural history studies is that persons who have C3G who are untreated or not treated well, they lose anywhere from 7 to 10 milliliters per minute per 1.73 meters squared of glomerular filtration. So that's that quote that you'll lose your kidney in 10 years, roughly. You lose 10 a year and you started at 100, for instance. So that's actually where that number comes from. And in fact, it's been reproduced in a number of the natural history studies. And in this particular study, it was also, you can see that sorry, guys, go back. You can see that before they started iptacopan, there's a fairly sharp decline in the kidney function. And in fact, it was what was expected, 7.57 milliliters per minute. But once you started iptacopan, then in fact, you got a flat curve. So now your GFR is stable, and that ends up being the very critical aspect of this particular trial. Of the two trials, this particular aspect of this one is the better outcome, if you will. Again, we're trying very hard not to choose between these two. I'm just going to point out in each case which is the better feature in terms of for you to be able to think about. Okay, so the next trial. This is the C3B inhibitor called pegcetacoplan or Empaveli. It's a infusion twice a week, and it's done by this little, I call it a hockey puck, but you either place it on your belly or your thigh or your arm, et cetera, and it sits there anywhere from 30 to 45 minutes delivering the agent, and again, you do that twice a week. This one was FDA approved for 12-year-olds and up, native and transplant kidney. Remember the other study, their transplant, you'll have to go back to the prior publication to get the transplant data in the other study. And it was also approved for C3G and immune complex MPGN. And by the way, there was a rat model that suggested that this was going to be a successful approach. This is their 26-week data, but because I gave you the 52-week data on the other study, I'm going to focus more on that. But really the important piece here is that they also had a very nice urine protein reduction. They had a stabilization of the GFR, And they had a very significant reduction in the C3 deposition on the kidney biopsy, which that is probably one of the more impressive pieces about this particular study. The other study did have C3 deposition, but they just calculated it differently. They collected it differently. So it's a little bit hard to actually compare the two. But at 26 weeks, so 6 months into the study, if you were on pegcetacoplan, 71% of those patients actually had complete loss of C3 deposition on their biopsy. So that's pretty cool. And it didn't, with respect to urine protein, it didn't make any difference which group you're in, adolescent, adult, C3G, immune complex MPGN, transplant, no transplant, you still got a very nice urine protein reduction, which you can see there. At 12 months, so at 52 weeks, now you have in the initially treated and always treated pegcetacoplan group, now you have a 67.2% reduction in urine protein. And those that were on placebo that are now being treated with pegcetacoplan, they now have a 51.3%. You may have guessed or thought this is why we think that treatment as soon as you can treat is good, because notice the delay in treatment of 6 months for that group of patients was not ideal. Now, it's possible we follow them another 6 months and they'll catch up, but that's part of what triggers us to think that treatment as soon as you can do it is an important thing to do. And then finally, the GFR. Now you can see it out. I showed it to you at 26 weeks. But this is their GFR at 52 weeks. In the group that was treated the group that was treated all along, they have a minus 3.7 versus the group that was at placebo initially and then treated as minus 4.7. So remember the standard we believe in a C3G patient is 7 to 10 a year. So this drug also facilitates stabilization of the GFR. So last slide. Even though we have these 2 new stops on the treatment highway, we have a ton of questions that we still have to actually tackle. How can we make the diagnosis faster? I gave you those confusing points. How can we get rid of those pieces of confusion? How do we use the biomarkers? Of course, that's a very important part for Moral to be thinking about. How early will we start the AP blockade? My current guidelines say wait to a gram. Right? That's what the global guidelines are. We don't practice that way, but it's still out there that we need to wait for a gram. How do I choose which AP blocker I need? If the transplant, if you're a transplant patient, can I treat just histology or do I have to wait till you have a gram of urine protein? To be fair, the study did wait till they had a gram of urine protein. So that's the most consistent with the trial. And then finally, how long do I use an AP blocker? Because that's going to be something that's actually going to be the very next question you all are going to ask once you get up and running on one, if it's necessary. And then finally, what are the types of safety things that we have to deal with? We talked a lot about safety this year. You know that if you're on a complement inhibitor, there are safety issues that we have to pay attention to. Thank you. So as usual, I talked very fast. So there is time, a little bit of time for questions. Silence, yes. So I've done it. We had our room yesterday. My question is now, I really didn't understand that they address 2 different things. It's not the exact same. They don't work the exact same. So you're going to tell me that the pill is better for my son? Yeah, so I still, on this day in 2025, I'm not going to be able to choose which one is going to be better for your son, frankly. I'm going to go back very quickly to this figure, ignore the fact that it happens to be for the pegcetacoplan, but notice C3 is here and B is here. So blocking B, which is iptacopan, or blocking C3, which is pegcetacoplan, is really essentially exactly in the same place. I'm overstating that, but so in theory, they both block the convertase activity. I should have Hector answer this, right, Hector? right? In theory, they both block the convertase activity. So they go to where we would suggest that you need to go to. Um, they have different results. And to a degree, they're like comparing apples and oranges because one study enrolled a lot more children. The other study didn't enroll any children. One study enrolled, so they enrolled very different groups of patients. So it is sometimes a little bit hard for us to be able to look at their answers and say, oh, this is the best answer. For instance, I'll just be explicit. One study had a much higher reduction in urine protein. Is that because there were more children in that and because children are a little bit more likely to get a better urine protein out of the deal? I don't know. Flip that over. The other study ended up at 12 months with the better GFR. As a clinician, do I pick the GFR? I've been trained that if I can reduce the urine protein, I'm going to preserve the GFR. So you can see that there's lots of pieces of this that actually get quite confusing at this day. Now, I believe we'll be able to sort it out and figure out if one of them is better or even one of the newer ones that might be coming is better. But right now, it is absolutely fair for you to choose, first of all, the one that you want to try. For instance, if you want to try by mouth versus whether you want to try infusion, it's absolutely fair to choose the one you want to try. Then it's my job to figure out whether it's working for you or not. And if it's not, then we have to try the other one as far as I'm concerned. Yeah. On the underside, we don't use it. Anybody yeah, Monica. And very frequently, once these medications are started, we're thinking about downsizing all of their other medications. So what we don't want to have to do is go back and forth, right? So if we're good and happy on one, and then I back off on all the other medications, and then we stop taking the one that's the support, if you will, I have no background medications to be able to continue supporting the patient. So the compliance issue is incredibly important, actually. It was a total waffle, and I get that, but we need more time. We need a little bit more time. We have not, again, because of where they work, we have not thought of using both, but Richard even brought up, oh, actually, it might have been in one of our clinic visits. Way back in the day, we did use two of them together, and we got better effect. That this was a long time ago. But the point of saying that is that if they have two completely different mechanisms, it may be reasonable, but the real problem is how much more do you increase your infectious risk by doing that? So, but it is. It was eculizumab and SCR1. SCR1 was one of the very early complement inhibitors that we used, and it turned out that it worked much better in our patient who happened to be on eculizumab also. So, but we have not thought about using these two together just because they're very similar mechanisms with respect to where they block. Thank you.